Okay, good morning, everyone, and welcome to the first grand rounds of the new academic year for the interns. And nice to have a good showing of interns here in the Cohen Center. And hello to everybody out in Zoom. So today we have, from my memory, the first ever pediatric podiatrist here presenting at grand rounds. Dr. Sophia Stocks is a podiatrist and owner of Arizona Foot and Wound Specialist, a private practice in Central Phoenix near the Arizona Biltmore. She's also an associate professor for Midwestern University College of Podiatric Medicine in Glendale since 2017, where she continues to teach lower extremity anatomy and is a clinical preceptor for medical students. Dr. Stocks completed her surgical residency at the Carl Hayden Phoenix VA Hospital in 2020 and has since been in private practice working with patients of all ages. Before attending podiatry school, Dr. Stocks was a high school teacher for several years in Houston and also lived abroad to teach in South Korea. She takes pride in continuing to educate her patients, medical students, and aspiring pre-med students as they rotate through her office. Without further ado, Dr. Stocks, welcome. Put that on that. There you go.
Good morning, I'm Dr. Stocks. Thank you so much for having me here, and thank you for joining on a very, very early morning. And hopefully today I get to share with you guys a little bit about my passion. And I love people, and a lot of people, they come into my office and they say, do you love feet? Is that why you're a podiatrist? So here's a little secret. If I don't have gloves on, I am not touching your feet. So I'm going to share with you a little bit about feet. And also I want to thank Mary, my third year medical student, that put blood, sweat, and tears into helping me with this presentation. So let's get started. This is where the magic happens. This is my office. We see a lot of children, we see a lot of adults. I don't think people recognize enough how tough it is to be a physician, a clinician, a surgeon. Whenever you guys went through those sleepless nights studying for your NCATs, going to your interviews, surviving med school, taking your boards, going through residency, and now you're taking call, answering pagers 3 in the morning, 5 in the morning, waking up early to round. People don't understand enough how much training physicians have to go through. And not just that, once you graduate residency, now you're an attending. The patients come in and they look at you and they expect you just to be able to snap your finger and know their diseases, their diagnosis. And so hopefully today we get to debunk some of that pathology whenever your patients come into your room and they say, I have foot pain, doc, and it hurts. So you don't have to be like, well, where do I refer you? I want you to be able to systematically look at the feet, touch the feet, and hopefully you can diagnose 95% of that foot pathology when it walks into your office. And if it gets a bit more complicated, then you can send it out. So in my office, I do have a lot of med students that rotate with me. And Midwestern is a really sweet spot in my heart. So let's get started. Today, we're going to go over the basic foot exam. And we'll go through common foot pathologies in children to include ingrown toenails. We'll talk about flat feet, Seizures disease, and then the nasty warts. We'll also cover some interesting pediatric clinical cases that have gone through my office. And then finally, when to consult podiatry. And then there will be a bit of time for some Q&A at the end. So starting with the basic foot exam, you don't have to freak out and think, oh my gosh, back to anatomy, every little ligament, every little tendon, every little slip, every muscle, belly, artery, and nerve. You can put that on the back burner. It's good to have learned that in depth during your anatomy courses, but all I want you to remember for a basic foot exam is V, D, M, and N. If you remember these 4 letters, you're probably not going to miss what's going on in the foot. So for V, that's going to be your vascular, D is derm, M is musculoskeletal, and then for N, it's your neuro exam. Whenever you're looking for vascular, you're going to be checking for DP and PT pulses. Also, you can pinch the foot underneath and check for cap refill time. You want that to be brisk. You want the toe to pink back up under 3 seconds. If it's sluggish, it takes more than 3 seconds, or you're counting 12 seconds before the toe pinks back up, then you can start worrying. And don't underestimate the power of just feeling the child's foot. If it's warm, that's good. If it's ice cold, you have to start suspecting is there ischemia or something that's going on. So when you're looking for your DP pulses, you want to start with the middle and the top of the foot. or something that's easier that they taught me in residency is look for the second metatarsal head, or that knuckle, the second knuckle. You follow the shaft of the metatarsal proximally until you hit the base, and that's where you'll find the DP pulses. If you're looking for the posterior pulse, you just use 2 fingers, you wrap it behind the medial malleolus, and that's where you'll find the PT pulses. For derm, you want to overall just inspect the feet. Don't forget to look between the toes. There have been so many times where you can miss an ulcer, you can miss a foreign body. I've pulled a toothpick out from between children's toes before. You want to look for any discolored skin, macules, lesions, or any raised lesions on the feet. You can also check for scaling. Scaling is abnormal on the feet. Could it be a fungus? Could it be eczema, some type of a contact dermatitis? And then don't forget to check the color of the nails. It should be clear, and the thickness of the nail should be thin. And this is your money slide. If you don't remember anything else on this presentation, probably should take a screenshot of this slide. If you know this slide, you can probably diagnose 95% of injuries or foot pain for children or even adults that walk into your practice. Whenever you're doing your musculoskeletal exam, you always start with the metatarsals. So whenever you look at the metatarsal heads or the knuckles of the feet, you can start palpating from the head or the knuckles, and you go proximally 1 by 1. So the second metatarsal, third metatarsal. If there's tenderness along the shaft of the metatarsals, then you can suspect either a fracture or a stress fracture in your patient's feet. And that can be from overuse syndrome or bad mechanics. If the child doesn't have good arch supports or shoes and their feet are smacking down into the ground when they're walking, it can accumulate into tiny little cracks on their feet, which are stress fractures. And then also you can palpate between the metatarsal heads. And if there's tenderness, whenever you're squeezing in between those knuckles on the child's feet, then you can suspect a neuroma or swelling or pain in the nerves that run in between the metatarsal heads. Next, we're going to go through 3 very common tendonitis issues in the feet. You can palpate posterior, following the Achilles tendon until it wraps around and inserts on the back of the calcaneus. If you have tenderness along the Achilles tendon, then you can suspect Achilles tendonitis. And then remember when we talked about the PT tendon, when you're behind the medial malleolus, palpating that artery, if you start there and you follow the tendon path down to where it inserts onto the medial arch of the foot at the navicular, if there's tenderness along that pathway, then you can suspect posterior tendonitis. And mirror that on the lateral side of the foot. When you palpate behind the lateral malleolus, if there's tenderness, you wrap it around all the way to the base of the fifth metatarsal, then that could be a perineal tendonitis. And then really important one that you would probably see a lot in children's would be Seaver's disease, or an inflammation of the growth plate in the calcaneus, and that's done by a heel squeeze test. And there's going to be a slide in the future where we'll go over how to perform the heel squeeze test. And don't forget your neuro exam. You want to take out your monofilament, perform a Babinski, checking sharp dull on the children. So let's go ahead and dive into some common pediatric foot pathologies. We're going to start with ingrown toenails. So between 2 to 5% of children experience ingrown toenails. It's usually the great toe that's most affected. You'll find it in teenagers, young adults, and usually males will have it more than females. And I do see it a lot on the lateral border or on the border of the great toe closest to the second digit. That's usually affected. There's logic behind all this. So some things you want to look for in an ingrown toenail is that your patient usually will present with some pain, some tenderness along the edge of the toenail or the skin folds near that nail. There might be some swelling, some redness, some drainage, and then patients might complain, man, it hurts just putting on my socks hurts, or touching it hurts, or wearing shoes hurts, walking hurts, because you're propelling and you're pushing off on your great toe to be able to move forward. And then any pressure that's exerted on that toe is going to elicit pain. And then, let's see. So things that are causing the ingrown toenails is usually there's incorrect toenail trimming. I know some of you guys might think it's better to have a little rainbow shape or cutting your nails into a nice curve or rounding off the edges. That's actually one of the biggest causes of ingrown toenails. Or if your shoes are too tight, the nail bed is very pliable. Whenever your shoes are too tight or you're wearing high heels, or children who are shoving their feet into a shoe that's too small for the shoe size or we're growing too quickly, that shoe can put pressure on the nail, which bends it, and it causes vice grip on the tissue, leading to ingrown toenails. Trauma, dropping an object on it, dropping weights on it, kicking your bed can lead to an ingrown toenail also. And then also the shape of your nail. Some people were born with more of like a pincer shape or a cup shaped nail, or those who were born with wider plates. Nail plates tend to get more of an ingrown toenail. Or if you have a genetic disorder such as psoriasis, or if you have like fungus in your nails that cause it to be thick, these are all kind of precursors for putting you at higher risk for ingrown toenails. So what are some self-treatments that you can recommend to your patients before, say, going through a procedure that you perform on your patients? You can have them doing some Epsom salt soaks, or even a really good one is massaging away that nail edge that tends to be puckered up against the nail that's ingrown. By decompressing it, by pulling away that soft tissue from that border of nail, allows for drainage, allows for like some breathing space for that ingrown toenail to sometimes resolve on its own. I'm wearing open-toed shoes, so there's less pressure directly over that nail, or just trying some over-the-counter medications like Tylenol or ibuprofen is a good place to start. And when's it a good idea to send to a podiatrist, or if you guys can perform the procedure yourselves? Say your over-the-counter methods fail, or if there are signs of infection, then you probably want to have some type of a procedure done. If there's infection, that means there's invasion of that nail into the soft tissue. Now there's a portal of entry for bacteria to seek deeper. And even if you put the patient on antibiotics, that foreign body is still embedded in the tissue. You probably want to remove it in order to avoid future or further infection, which could lead to bone infection or osteomyelitis. Or also if you see visible trauma to the nail where it's loose, it's oozy, it's nasty, don't wait. Even if it kind of deflates after a week or two and improves, that trauma to the nail bed, you can't see what's underneath. Could it be an open fracture? Could the distal phalanx of that digit be exposed, or there's a break in the skin? This would, yeah.
There's some people are saying I forgot to do this, so.
Thank you.
There we go.
Yes, so whenever there's trauma to the nail, you want to make sure there isn't a fracture. It's a good idea to take an x-ray, and on lateral, if you can have the patient elevate that hallux, you can see the distal tuft. Has it been fractured? If you have an open fracture, or if it's exposed through that nail bed underneath the nails are super, super dirty. You want to be able to culture it. You want to make sure to clean out an open fracture, put them on the right antibiotics to avoid osteomyelitis or bone infection, or the risk of even having to deal with IV antibiotics for 6 weeks, or excision of infected bone.
I see what they're talking about. Is it blocking the vision? Yeah, it's showing. Oh, I get you. I know. Let me try it over here.
Where'd our IT guru go?
Yeah. Said he had to go set up his studio, so yeah. Oh, it's good now. It's fixed. Okay, thank you.
Okay, proceed.
Yes.
All right, let's keep going. Alrighty, so what's the difference? If you were to send to a podiatrist, the first thing we always start off with is x-rays. You want to look at the cortex of the bone, and you can see the little growth plate there in the distal phalanx. What you want to make sure that there's continuity of that cortex or the wall. If there's a break in the cortex, if you go from progression of A to B to C, you notice that there's some portable erosion to the distal tuft, which looks like a cookie bite. Like if you're gonna take a bite out of a cookie, that's the beginning signs of osteomyelitis. I see this plenty. And 15-year-old that was sent to me with bilateral ingrown toenails for a whole year. His big toes were so inflamed, so infected that he was embarrassed. He would take his socks off. In gym, he would shower with his socks on in order to avoid his classmates seeing his ingrown toenails. So in cases like this, you have to put the patients on antibiotics. You want to remove the ingrown toenail or the foreign body and see if the bone can rebound without having any amputations or further surgical resection of the infected bone. Things that we would do in the office, we could remove part of the nail that's infected, or sometimes the entire toenail even to decompress. In severe cases, like I said, you want to take a culture and be culture driven whenever you're handing out antibiotics, especially to children. And then really importantly is to address the biomechanics of the foot, how you walk and how the pressure accumulates against certain borders of the nails will lead to recurrent ingrown toenails. So we're going to talk a little bit more later about orthotics. And then there are permanent procedure options that are performed in the office also. So that little sliver of nail does not grow. So prevention, things that you can have your patients do is when they're trimming their toenails or when parents trim toenails, make sure you cut straight across, file the edges. Kind of avoid the temptation to trim in a little rainbow shape. You want to wear properly fitting shoes that are wide enough. You want to stick your thumb at the end of the shoe and make sure there's about, the width of your thumb at the end of the shoe to make sure the toes aren't banging up into the distal edge of the shoe. Other options are you can have the child wear toe spacers where you physically take off pressure between the great toe and the second toe so that nail isn't continuing to fold on itself, causing recurrent ingrowns. If all else fails, you're welcome to send to a podiatrist to assess their biomechanics, see how they're walking, how the toes are kind of pushing up against each other to help prevent ingrown toenails. So if you look at this image of the flat feet on the top left, as the mid arch or the instep of the foot kind of flattens and rotates into the ground, you'll notice how the great toe also starts to rotate into the ground. And attached to that great toe is the medial edge of that nail. The more that you're propelling and you're pushing off on that great toe, and that medial edge of nail keeps banging into the ground, it's only a matter of time before that child or even an adult gets an ingrown toenail. And not only the medial border, the ground reactive force is pushing up against that great toe, now lateralizes that great toe, and you start developing a bunion. So people might think, oh, bunion's just a crooked great toe going over. No, look at that great toe. Now you're squeezing that lateral edge of that nail, putting it up against the bone of the second digit, which is going to overpower that pliable nail plate, causing an ingrown toenail in the lateral border of the great toe. So, oh, I love this cartoon right here. The great toe is like, which way do I go again? This way. In here, this way. In here, are you for real? Doesn't make sense. Are you sure this is the right way to grow? So you're sometimes ingrown toenails, they have a mind of their own. But I have a little video for you where we'll go over the surgical technique of how to remove an ingrown toenail. We'll go through the injections, the method of how to inject a toe. Never go into the end of the toe. That's not very nice. And the smaller the gauge needle, the patient will probably like you a bit better. So here you go. Let's get started. Today, show your face on the screen page. Say, what does it do yourself?
I'm John.
He is. He's going to do great for the known stubborn. Okay, my dear, so you've been told vocal, squeeze a little stress ball, okay? So what you just do is make sure you inject the base of the toe where the nerve is. And you'll see the skin pop up. Okay, John? And hard pulls and gets toes and non. So when you're injecting, you want to find the base of that toe where it kind of flares out and it's squishy. And right when you penetrate the skin after you cold spray for about 2 seconds, you'll make a little wheel or a little mosquito bite under the skin. You inject and advance. You drop a little bit more and then you advance. And you're always aiming for the plantar central aspect of that toe. So a lot of the neurovasculature is plantar that innervates that toe. The plantar prick isn't necessary, but if you do that, then most likely you'll know the toe pretty well if you do that side prick. They shouldn't be able to offer your first initial injections. And you can dorsiflex the great toe to get the tendon out of the way so you can inject the bottom of the toe a bit better. No.
So I'm gonna squeeze around a little bit. Is that pressure or is that sharp? Right, squeeze a bit more. Pressure, sharp. Good. On this side, do you feel a bit of pressure or is it sharp? Good. Are you neuropathic or diabetes? No, that means you're not pretty good. Blood is good. Blood means that you can feel. Underneath there, I'll squeeze a little bit. Pressure, sharp. Excellent. I can tell you that it's telling us a while. You want to loosen up underneath the nail. Above where the cuticle is, you slow out medially. Same thing on the lateral side. You do the cuticle. You go underneath and you can give a bit of a push. We always want to have negative pressure. So like the spatula, the proceed forward. You slow out laterally. And then now we take the hand up. And there are two sides of the hand. Look at the pointy side, keep it down. And then you want to take off in the opposite direction. So they make it first cut before the cuticle. You always block it so you can make blood pass. The side snip, you want to go underneath the cuticle. Good job. And then on the lateral side, same thing. You want to take enough to provide relief for the patient. For the cuticle. Snip. And then you go underneath the cuticle. And snap. You did great, John. So during the one bit, you okay? You always want to lock your nail as far back as you can. You always rotate to the central plantar aspects of the toe. Just let it soften. Feel it. There's the little guy. And I think you're famous here on INGROWN again. And then we're gonna lock the lateral side. Always rotate and drop the hand to the central bottom part of the toe. All right, so thread and head out of your toe now, and all you want to do is make sure you remove any of the scar tissue that could be remaining on the toe, just to help him feel a little bit better. All this extra scar tissue, chronic ingrown, can cause him some pain and things. And then there's any scar tissue. There's a healthy wound base. What you want to see is that red base of skin grown nails over there. These are the little puppies that came out. You want to see that? So this is this guy over here. And this is this guy on this border. Awesome job, John. And that's it. Good luck.
We'll just go to the next one, Dr. Hurley. Perfect. So that was ingrown toenails. We're going to move on to talking about flat feet. So about a quarter of all children are going to have flat feet. It's very common, particularly in infants or young children. Usually boys have flat feet more than girls. And then this has a lot to do with like physical development. A lot of the children, they haven't developed their muscular tone yet. And so they'll tend to have more of that flat feet whenever they're younger in years. So the younger you are, the greater the probability of having flat feet. So signs of flat feet, you'll have the patient will have tenderness, particularly say during activities or fatigue, weakness in their feet or their legs. They'll avoid running, jumping, or walking long distances. When you look at the foot, if the inside of that foot looks like it's kind of kissing the ground, then that's a flat foot. The child might complain of their shoes not fitting, or parents noticing that the medial side of that shoe edge might be grinding up against their arches. And we want to look out for the too many toes sign. So if you're behind the patient, you notice that too many of their fourth or the fifth digits are peeking out from the side, that's the too many toes sign, which is an indication of flat feet. So there are two types of flat feet. There's the flexible flat foot and then the rigid flat foot. The most common type is the flexible flat foot, and usually this resolves on its own as a child grows and develops. So whenever the child's sitting there on your examination table, you'll notice, oh my gosh, they have an arch. But parents are like, no, my kids' feet are like pancakes. They step down, that foot is as flat as a pancake on the ground. That's a flexible flat foot. While the child is sitting there in the chair and the feet's completely flat already, whether they're weight bearing or not, then that is a rigid flat foot. And whenever it's a rigid flat foot, no matter what position or how much weight they put on their feet, you have to start suspecting, is there a skeletal deformity deeper down in that foot? Are the tarsal bones coalesced? Do you have a coalition where there shouldn't be, or were they born with, say, their talus in a vertical position, causing their foot to be in a flat presentation? You can have the patient do a heel rise or a tippy toe test. Whenever they get on their tippy toes, does the heel flip or invert back in, and so the arch reforms? If so, that is a flexible flat foot. That's good news. If they're getting on their tippy toes and the arch does reform, you can control this flat foot with an orthotic inside of the shoe, so that when they're walking, they can still have an arch, and it would minimize their arthritis as well as slow down the bunion progression. Say the patient gets on their tippy toes and that heel that was in a lateral or valgus position, it stays in a valgus position, then it is a rigid flat foot. You would then probably want to order an x-ray or send them out just to make sure you're not missing any bony deformities that are deeper in the foot that could be addressed at a younger age, where the child can develop better biomechanics. Say if they had a resection of a bony bridge that shouldn't be there. And why are we harping on flat feet? Because a lot of you guys here might have flat feet. If you look at the rear foot, if it is flat and your subtalar joint or your talus and your calcaneus, it's flipped out by 2, 3, 4 degrees, you can imagine this is like the foundation of your home. If your feet and your heels are not perpendicular and you are flat, this can lead to higher up deformities, such as maybe even knee pain, hip pain, neck pain, back pain. If the foundation of your home isn't straight and aligned, you can imagine after many years, 5 years, 10 years, 15 years, you'll see cracks in your drywalls. You'll have foundational issues, but you'll have issues up higher in your home. Same thing with your body. If your feet are not aligned, if the child's foot is not aligned, you can imagine they might have unequal wear and tear of the cartilage in their knees, their hips kind of funny, they start having a bit of scoliosis, and it all starts from the foundation of the feet. So noticing flat feet and the posture of the foot is very important from a young age. So what is the treatment for flat feet? Starting with supportive shoes is the key. You can even take your own shoes off and check them out right now. If you were to bend the shoe in half in the arches and the mid arch, then it's probably not a good shoe. You want to, if you're wearing Converses, that's a no-no. So you want to find shoes that are solid. The base needs to not bend in the mid arch. Imagine if your shoe is too flexible, that means that your feet are ultimately absorbing the shock. Your feet, your joints are bending and inverting as you're taking every step. And imagine if you're running, hiking, doing sports activities, you're wear and tearing your joints, kind of bending them in a position that is past their point of where they want to function. So supportive shoes for your patients. Maybe even high top shoes are a good idea. If it's a high top, it stabilizes their ankles a little bit better. And then orthotics. I can't stress this enough. Having a device deep down underneath the foundation, especially for a flexible flat foot, helps to derotate that foot so that it can be perpendicular, and it helps that child with development and functioning and growth. Physical therapy is a good place to start also if you want to have the child exercise, do stretches to strengthen the musculoskeletal structures around their feet and their ankles. That's a good thing to do. Managing their weight and exercising is a good idea. The heavier the child gets, more of that the gravity pull, their weight ends up going down the medial side of their feet and their ankles, causing the flattening of the feet. And then finally, surgical interventions. You could do flat foot reconstruction. There are implants that can be placed in the foot in order to kind of jam that joint so it doesn't continue to flare out. Or if there's a tarsal coalition, you can resect it to allow for better motion. And that's my child there. That's Tessa. She's got flat feet. She's almost 2 this week in a few days, but her flat feet are okay. So that's Haley and Tessa. A little break in the presentation. My 4-year-old, my almost 2-year-old. And then we'll hop on to Seaver's disease. So what is Seaver's disease? It's the most common cause of heel pain in kids, usually between 10 and 12 years old. Males usually have it more, and in most cases, both feet or both heels are affected. And you'll find this mostly in children who are active in sports. So it's an inflammation or sometimes even a partial avulsion of the growth plate in the calcaneus. It is an overuse injury. So when you're repeating the same motions, you're running, you're jumping, there's a lot of micro trauma from that Achilles tendon that constantly pulls on the back of that heel bone where that growth plate sits, and it can lead to Seaver's disease. So some risk factors is if the child has really poor flexibility in their calf muscles, that could lead to Seaver's disease. Imagine if your calf muscles are super tight and the patient tends to walk on their tippy toes. Each step that they're running, they're hiking, they're jumping, that heel just kind of slams into the ground. The Achilles tendon causes traction on that growth plate, and now they're going to have Seaver's disease. So patients who have flat feet, or sometimes the cavus or the higher arch feet, tend to get Seaver's disease, or if they have a genuvarum or that kind of bow-legged shape, that's a risk for Seaver's disease, or if their footwear is worn out, this can also lead to Seaver's disease. So on x-rays, you can see sclerosis of the back of the heel, which is kind of a telltale sign of Seaver's disease. You can also look at the bottom left over here. You can perform a heel squeeze test in your office. When patients come in with pain, you put their heel in the palm of your hands, and then you give it a good squeeze centrally. And if the patients retract their leg, or they're like, oh my gosh, that hurts a lot, you can bet your money on it. It's most likely Seaver's disease. You can also palpate posteriorly along the Achilles tendon. Usually the Seaver's disease is coupled by an Achilles tendonitis. You can also check the amount of dorsiflexion or bend in the ankle joint. So past the perpendicular, you want to have about 10 degrees of dorsiflexion in the ankle. If the patient can't get to 10 degrees, they have a very tight calf muscle. That's something you want your patient to work on, but don't worry about doing all these calf stretches when they're in the acute phases of healing. Whenever they come in with that initial heel pain, don't be telling people to stretch. Nobody wants to stretch when they're in pain. You're going to calm down the inflammation, make sure they have a good time, and then after that, during the recovery process of rehab, you can have them doing calf stretches. If all else fails, you can also order an MRI to confirm if there's Seaver's disease going on. What is the treatment? Oh my gosh. So rice therapy, not eating rice. I love rice, but you want them to rest, ice, compress, elevate. You can also have the child decreasing or stopping their physical activities if possible. A lot of your patients sometimes are high performers. They're in sports where they have to keep playing. If that's the case, I tell the patient, you realize you're going to slow down your rate of healing, or maybe try to get into a device if you can't, stop running in general, just so that you have better traction or better mechanics through that Achilles tendon, so there's less pull on your growth plate. Other options are casting your patient or putting them in a walking boot. I don't like casting. Casting can be a bit messy. Patients, the younger ones, they pick at it, they shower, they get it wet, they poop, they pee on it. Not a good idea to cast. I would say put them in a walking boot so they can take it off, shower, put it back on. Physical therapy and stretching, good idea. After the acute phases, you don't want to have active stretching right when they come in, they have Seaver's disease. Calm that little puppy down so that they're in less pain, or when they're 80 to 90% improved. Then the longevity of trying to inhibit this from coming back is to do stretching, physical therapy, and ultimately wearing orthotics. So if you imagine your feet are like the foundation of your home. For children, they're very flexible, and as they're running, you have the anterior tib tendon, the peroneal tendon, the PT tendon, the Achilles tendon, all attached onto the foot. If the child's foot is unstable and wobbly as they're walking and they're running, this is going to cause the tendons, which are like the reins on a horse, to over tug and over pull in order to stabilize the feet. That would cause tendonitis. If they had an orthotic or a solid device underneath their foot, then that would allow for stability. And guess what? Less pulling on the Achilles tendon, less traction on the growth plates, less likelihood of recurrent injuries. And then we'll hop into warts. So the general public has about 10% of us get warts. In kids, 1/5 of them will have warts. It peaks around school age from 12 to 16-year-olds. If all else fails, don't worry. In about 2 years, 2/3 of all cases of warts kind of goes away on its own. So this is caused by the HPV virus. You can get warts from skin to skin contact, or if your skin is broken down, or if you have wet, moist skin, say at the pools, the gym, the locker room, your pores start opening up. It helps you receive the shedded warts virus into your foot better. So for diagnosis, things you can do is you can differentiate between, say, a wart and a callus. If there's direct pressure right when you push it, that's probably not a wart. But if you do a side-to-side squeeze, that's very classic for warts. If it elicits thickness and pain and tenderness and you squeeze it side to side, then that's most likely a wart. And then you can also look down here on this diagram, the little blue lines, those are your skin lines. If you don't see the skin lines through the lesion, it's most likely a wart. And then if you look at the top right, if you think about it, a wart is kind of like a tumor that's growing on your foot or your hand. And it's so intelligent that it ends up releasing local hormones and growth factors for your blood vessels to feed it like a little tumor. So if you were to shave down this lesion, or if the patient messes with it or uses a pumice stone and they notice a little tiny punctate bleeding, that's pretty classic for a wart, because now you're exposing the tips of those blood vessels that have sprouted to feed the wart. If all else fails, you can perform a biopsy and send to pathology to confirm. And if you've treated for warts, it's not going away, you have to start thinking of other things. Could it be a squamous cell? You don't want to miss something that could be a bit, scarier. So there are thousands of treatments for warts. Why is that? Because not one way works. Warts suck. So what you want to do, there are options. You could do salicylic acid, cryotherapy, there are bleomycin injections, by the few injections. I've heard duct tape being used, honey, lasers, surgical excision. Worst comes to worst, sometimes doing nothing, and it does self-resolve over time. And we'll hop into some clinical cases. So I have a 16-year-old female sent to my office stat consult for right foot pain for a bump on the foot for about a week, suspecting possible foreign body. The mom said she had fevers up to 102 Fahrenheit. Vitals were within normal limits in my office. She had been on Keflex and some ibuprofen. And in the office, we noticed some lymphangitis, some streaking of the lateral side of the foot and ankle, and there was a fluctuant abscess underneath the heel. Even in the office, the patient was kind of reluctant to have any procedure done, afraid of pain. So we did do an IND. I didn't have to number up. Whenever you have a patient in your office and you feel like there's a bubble or there's like a fluctuant kind of mass there, you probably don't even need to numb them up, because that tissue has separated enough to where there's no innervation there. It's already dead. They can't feel pain. You could just do a little sliver or a slice right through that fluctuant area and it starts to drain on its own. We did an IND to remove the foreign body in the office, did some deep cultures, and then I placed her in a weight-bearing walking boot, and she performed daily dressings with betadine for wound care. And this is what the foot looked like after we excised the foreign body that looked like it was laying inside of her heel. She woke up one day and it just was red, it was swollen. I didn't do anything. She didn't know how it started. She kind of woke up with this little bump on her butt. And that's what I removed from her heel. It had two little arms. To me, it looked like two little arms. Anyways, the path report came back as necrotic gangrenous tissue. Personally, I thought it looked like a butterfly or some type of maggot or a Disney character. But you know what? If in doubt, don't question your pathologist. You send it away and they tell you what it is. So after a week, she healed it really well. Putting her in a walking boot, and children, they're phenomenal at bouncing back from wounds, from tendonitis. What takes an adult to heal, I'd say like a fourth or a half of that time frame. Children, they bounce back and heal super well. Second case, 14-year-old male, chief complaint of flat feet, some foot pain, some fatigue during sports. He's tried custom orthotics years ago, but then he outgrew them. Tried changing shoes without any, any help. And if you look, the medial side of that arch is kind of kissing the ground, super flat. Even his great toe is rotating into the ground. So you bet this child probably came to see me, not just with a flat foot, but it's eventually going to get an ingrown toenail on that medial side or even the lateral side of that foot. I put him into some orthotics. You notice the knees on the left side, it's a bit more of a genuvarium or that bow shape. In an orthotic, you have a bit more perpendicular knees. And then things that you want to look for on x-ray, this is not his x-ray, this is just an example, is if you have a tarsal coalition or that bony bridging between the calcaneus and the navicular, that sometimes could be the cause of the patient's flat feet. And then you want to talk to parents and the patients. Do you want to restrict it? Do you want to allow for motion back where it's been frozen so that the patient's foot and heel can swivel back into that perpendicular position? And then our third case, 10-year-old male here for left foot warts, possible left foot warts, right foot scaling, possible foreign body. Mom's not really sure what's going on. These little lesions have been on his feet for 2 months. They've tried over-the-counter topicals without any success. So on the right foot, so it's always the opposite when you're looking at the foot. The right foot in this picture has that typical kind of moccasin pattern scaling, which is consistent with skin fungus. So how I describe skin fungus is if you were to dip a dollar bill into a glass of milk and let it dry, and it has little circular little lesions, then that's pretty consistent with fungus. On the left foot, it was a bit more questionable. It had like a blistery kind of presentation. I wasn't sure if that ulcer, is there a foreign body underneath there, a piece of hair stuck in his foot that caused it to have that shiny kind of bubbly presentation. So in this case, you can always take a 15 blade or a 10 blade and just go at a very slight angle and start to shave down that lesion to see if it reveals either the foreign body, or if you see any punctate bleeding, then that would be more consistent with a wart. So after shaving it down, you can see the 3 little pinpoint bleeding holes, so it is consistent with warts on the left foot. And then the right foot, that's more of a scary case of skin fungus. Remember, when you see a wart, you do the squeeze test. So on this child, there were absence of skin lines, and then after debridement, we saw the punctate bleeding, and there was a positive squeeze test. There was pain on the squeeze test. And so for patients who tend to have these pathologies, you want to not only address the wart, address the fungus, but don't forget to address the hyperhidrosis. Patients who sweat a lot, they are predisposing themselves to pores and cells that are more receptive to inviting fungus in, as well as warts. So controlling the sweating, either with like their sweat sprays that they have, even certain dry that the patients can roll on their feet, changing their socks out more often, using foot powders, those are a good place to start. And then for my office, we like to use cantharone mixed with salicylic acid. Cantharone is a beetle extract from Canada, and it helps to blister that wart while allowing for the patient's own immune system to detect the HPV virus, to form CD4 cells to come and fight off the virus in the area. And the last case is a hospital consult for a 2-year-old that had a tourniquet toe syndrome. So whenever you're presented with a child with a toe that's kind of sausagey, has a line of demarcation that's not typical of where a skin fold should be, we want to suspect probably like a hair that's wrapped around that toe. Don't use a scalpel blade. That's not nice. You can have some Nair or some feet on hand. It's like a topical keratolytic that would pop that hair, and use the back of a Q-tip or a wooden probe and just put pressure after you've put the Nair or the beet cream around that hair, and it just kind of pops on its own. Okay. And then so when to consult podiatry or refer out your patient, when in doubt, you're welcome to send to podiatry. For flat feet, say if your child's over 6 years old and it's still flat, good time to probably send out. If the patient has heel pain or pain with activities or shying away from sports, send them on over. Lesions on the feet are not normal. If there are calluses, wounds, warts, those need to go bye-bye. So calluses are never just calluses, just like your face. You shouldn't have calluses on your face unless you're walking on your face. So there are pieces of under our feet, we have fat pads, we have pressure areas, and if they're not offloaded well, we form calluses. If the child is forming calluses, that means that there's undue pressure underneath the foot, and this can lead to fat pad atrophy. A flat foot does not absorb shock well. An arch actually is better for absorbing shock. If your child has flat feet, for example, and they're smacking into the ground whenever they're walking and they're running, not only are they accumulating stress fractures, but these calluses that form end up thickening, becoming like a rock underneath their feet, and it cuts into their deeper tissues. The fat that's in their feet start to move up into the sulcus area. In their 30s, 40s, and 50s, these children are going to suffer from metatarsalgia. They're going to have really thin fat pads or just like skin on bones. So you want to address this early to preserve the fat that's in their feet, so they can have a proper insulation as they age and they grow. And then also, if you have patients that have recurrent ingrown toenails that can't get rid of, probably a good time to send out. That's my family, Haley, Tessa, my lovely husband over there that came to support me this morning. And here are my sources. And then Dr. Hartley, if you want to share my slides with you guys are welcome to have a copy of it, read it up, and have some fun. And I want to thank my staff for showing up today, supporting me, and we're going to go into our Q&A session. Yes, go ahead.
And you mentioned orthotics a lot. There was a range, right? With custom ones that they spend a lot of money on. The long range advice you insert. Even some information on this investment.
Yes.
Good question.
Okay, so she was asking about orthotics. She said, do we go to Walgreens, where there are ranges of custom orthotics to temporary orthotics, you know, how should we approach our patients? So I've had patients that have come to me and they've brought in Dr. Scholl's inserts. Sorry, Dr. Scholl, if you're watching this, but Dr. Scholl's inserts, the ones that I've seen, are quite flexible. And so if your device that you're picking out of the store is quite flexible or flimsy, you can imagine your arches are made up of bones. If you're stepping down in an insert that is soft, your foot continues to collapse, continues to pronate, continues to flatten through a soft device, and that is not addressing your pathology. So you want to look for a device that is firm, that does not bend in half, just like your shoes. And then you also hopefully want to be, you know, ideally fitted by a podiatrist to make sure that the plate matches your arch height, because not all arches are created equal. So you want to make sure that the plate matches the height of your arches, but also it doesn't flare out too far. If it goes distal to your first metatarsal head, or if it eats into the head of that first knuckle, you're probably going to get a capsulitis or jamming or cutting into the fat underneath your metatarsal head. So you want a plate that matches your arches, ends before the first metatarsal head, and then make sure it's not too flexible. I've had patients that have gone to Good Feet, spent $1,200, and they're still in pain. They come to me, and then they still have to get the right device. So you want to be assessed to make sure that the devices that you have are the right durability, the right height, the right size, the right length, and then making sure once you get it, does it align your knees and your back? And breaking into it once a few hours at a time helps you get used to the devices. We have those in our office. Patients do have some success buying things online, but it's always good to bring in what you find to your podiatrist to be assessed to make sure it's the right ones for you. Any other questions?
We got 3 good ones here from the Zoom audience.
Okay.
I'll bring them up here so I'll read them into there. First question from me, our doc. How long do you have the patient wear a walking boot for Seaver's disease?
Oh, great. So how long do you wear a walking boot for Seaver's disease? A walking boot, so for my adult patients, I tell them they need between 6 to 8 weeks to heal a tendonitis. For children, I've seen them heal in half the time. I would say start with them in a walking boot in 2 weeks. In 2 weeks, they come back. Your goal is 50% improvement in pain. If they're not 50% better at the halfway mark, say at 2 weeks, then we have to start suspecting, is there something else that's brewing in that heel? But usually I would say by 3 to 4 weeks, they're back to sports pretty well.
Okay, very good. Second one from general pediatrics. Is there any utility to trialing over-the-counter orthotics as a first line, or should the patient always be referred to the orthotist or podiatry for custom orthotics?
Oh, good questions. I have seen a fair share of decent orthotics that are over the counter. If that doesn't work, then you're welcome to have the patients come into a podiatry office to be assessed. So it's not just an orthotic, but you want to align the foot to the leg, where the second digit is aligned with the tibial crest or the midline of the leg, and that is where the foot is ideally perpendicular to the leg. And then I hold the device up underneath your foot to make sure that arch height is where it's supposed to be. You're welcome to try stuff over the counter and then probably bring it in, and it can be further assessed if the patient isn't improving in their symptoms.
Okay. Next question, should cavus feet ever be referred to you, or should that be to ortho? And maybe talk a little bit more in general about what would go to you and what would go to ortho.
Okay. So the cavus foot type should the cavus foot type should be referred to me. So if patients are, say, complaining of symptoms with a higher arch feet, then it's a good idea to send, even just to preemptively be assessed. The higher arch foot also has its own types of pathologies. They tend to get very high pressure points right under their forefoot and on the lateral heel. So patients with the cavus foot type will end up having contractures where their extensor tendons are overfiring. And over time, patients who have the higher arch feet will develop these hammer toes where all 5 of their digits start to claw upwards, and patients will have their knuckles rubbing up against their shoes, which can lead to other pathology and pain. When we have a patient with a high arch foot, getting into a device that actually meets up to their arches, it allows for their hammer toes to relax. So preemptively sending a high arch foot would be a good idea, getting them into a device to allow for the tendons to relax. It slows down the progression of hammer toes and further pathology. And then if patients are interested in surgical procedures, say they don't like the way that their arches are, where it's too high arch or too flat, but then definitely go give, you know, ortho a holler, see if there are procedures that they can do to either putting an implant into the foot to slowing down the progression of a flat foot, or even doing a tendon Achilles lengthening in order to allow for relaxation of the gastroc muscle. So if that's what's causing their higher arch foot or some of the pathology, it should be assessed.
Very good. Another question I just had, some of the most, helpful studies in adults have been done where they take a group of people and they just follow them for 20, 30, 40 years and, see who dies from this or that. Has there ever been a study done where you look at teenagers' feet and then follow them for 20 or 30 years and see if you can predict based upon certain things what foot pathology adults are going to have? And then if you could, then is there anything that, we as pediatricians could be doing, to prevent problems, not that the kids are having right now, but that the problems the kids would get, in 50 years?
Absolutely. I look at children's feet today and I'm like, oh my gosh, you are going to have some nasty bunions if you don't get orthotics at a young age. And it's usually on point. I look at the children's feet and I look at mom's feet or dad's feet and I'm like, I know, those are my feet. So addressing it early, and patients who have more of that ligament laxity or tend to have instability at a younger age, if you can control that foot type, putting them into devices in their shoes, my gosh, they're gonna really perform better in sports. They're jumping up and down, they're trying to make it into the NBA or play football. Imagine if they had that support and that stability, less likely will they have injuries to their tendons and their joints. I have patients who come to see me in their 60s, their 70s, now they have no fat pad underneath their metatarsals anymore because no one told them about devices 40, 30 years ago. And so they've just been walking, grinding through their joints, their ligaments to where now their fat pad has absorbed all that shock and even shifted into the wrong location of the foot. Now they're paying $8,000 injections to plump up their feet. Dermabills for the base, I feel the foot up. So, you address it early, so you pay less later. And then the feet, as it deteriorates and it becomes crooked, you notice it years later when the knees are starting to wear and tear unevenly, your hips hurt. And then patients that had knee surgery on the right side, put them into a custom orthotic, anticipating knee surgery on the left. They're like, I'm gonna hold on, I'm not hiking, I'm going on all these trails. My knee pain is manageable and I want to have a couple more years before I do surgery. So every case is different. I can't reverse the arthritis that's already occurred. We can only just hope to put that patient into better alignment and hopefully have a bit more longevity before, say, having the knife.
Okay, we'll give a few more seconds for last question, either on Zoom or in the audience. If not, we'll, okay, yes, Dr. Jamshidi.
Ingrown toenails, do you want to comment a little bit on the use or not of phenol on the day?
Oh yeah, so Dr. Jamshidi was asking about the use of phenol for ingrown toenails. Very good question. I love using phenol on my patients, but I would only reserve it for non-infected cases. So a lot of patients, they come in, their parents are like, oh my gosh, this kid has had like 5 ingrown toenails or 14 ingrown toenails, and I'm tired of doing all these ingrown toenail procedures. But I'm like, lady, you brought your kid in when the toenail looks like a bullfrog, it's super infected. Imagine if you get nasty tissue or you're dealing with a wound basically from an infected ingrown toenail. Personally, I don't think it's wise to burn that already not so healthy tissue with phenol. For me, getting rid of the source of infection, getting a healthier skin base, and say have the patient come back in 2 months, where then you can perform a clean matrixectomy where you remove that border of ingrown toenail, just like the video, and now you can add phenol and a little Q-tip to that matrix, 30 seconds 3 times, and then you irrigate that wound bed with isopropyl alcohol. It does pretty well. I would say there's like an 88% success rate for patients who have the phenol added, so that the ingrown toenail doesn't come back. But I also tell patients it's not just the procedure, the mechanics is important, because you might make that nail skinnier, but if that great toe rotates into the ground and keeps kind of hitting the ground, that new nail edge is going to still shove up against that tissue and a higher likelihood of ingrown toenails.
One last question I thought of for adolescent females, and I'm sorry if this is going to be politically correct, but a lot of times men and women have the same size feet, but the women's shoes tend to be a lot of times very pointy and high heels, and they don't look very comfortable for somebody with a Y chromosome. What anticipatory guidance do you give teenage girls that maybe not have any problems with their feet, but let's say we're seeing them for a well check and you know, and we're starting to see that the toes are going in like that?
Yes, so whenever you check on your patients and they tend to like to wear high heels or they're shoving all that pressure into their forefoot. I think weekend outings, date nights are okay, but those shoes, even in my boots that I'm wearing today, I have orthotics in it. But you want to not progress, you don't want to chronically wear shoes like that too often, because our joints and our ligaments, they have the ability to rebound to some extent. The more that we shove our feet into tighter fitting shoes, over time, those ligaments, they can be overpowered by the pressure of tighter shoes. So those toes can end up with that bunion deformity or the hammer toes, just like the ancient, Chinese foot binding. You bind it long enough, it's gonna have funky shapes, right? So it's the same thing with wearing high heels over time. And then when you're in a high heel position, all of your forces are in the forefoot. So you can end up having too much pressure underneath where that fat pad is, and you can have fat pad atrophy where it ends up shifting and no longer insulating that metatarsal head, which can then lead to fat pad atrophy, tenderness, where patients come to me, they want to wear sexy shoes, they're in so much pain that I want to have surgery, then we got to plump up the foot, the fillers underneath the foot every 6 months to a year. But beauty is pain. You want the pain, you want the beauty, that's your choice.
Okay, well, thank you very much. And anybody who wants the PowerPoint, go ahead and send me an email. Okay. I think that's it. So next week is surgery ground rounds, and I can't remember who it is at the moment. Okay.